John Oro, MD, joined the faculty at the University of Missouri Health Sciences Center in Columbia in 1984 following completion of his neurosurgical training at MU. During his early neurosurgical career, he specialized in pediatric neurosurgery, surgery of the skull base, and cerebrovascular surgery. In 1991, Dr. Oro became chief of the Division of Neurosurgery and developed various subspecialty programs. In 1998, he and Diane Mueller developed the Chiari Clinic. Dr. Oro moved to Colorado in 2005 to become the Director of Neurosurgery at the Medical Center of Aurora. In addition to performing cranial and spinal neurosurgery, he expanded his National Center for Persons with the Chiari 1 Malformation. Recently, Dr. Oro and colleagues established the Colorado Chiari Institute at the Medical Center of Aurora. The Institute specializes in the evaluation and care of persons with Chiari 1 malformation, persons referred following previously unsuccessful surgeries, and persons with Syringomyelia or tethered spinal cord, enhancing the quality care mission, their commitments to research, education, and innovation. Dr. Oro has been listed among the best doctors in America since 2001 and America's top surgeons since 2002. We at CSF are so grateful to Dr. Oro for everything he's done for CSF and, most importantly, everything he's done for the patients who face a constant battle with these disorders. His dedication to these disorders is very appreciated, and we are honored to have him speaking this evening. It's with great pleasure that I introduce Dr. Oro.
Well, thank you. It's a real pleasure. You've heard a lot about Chiari Syringomyelia. They're really one of the preeminent societies for Chiari and Syringomyelia individuals and research. The Colorado Chiari Institute is our new delivery of service, if you will. I'll share with you a little bit later on. But hospitals are a modern miracle. What happens in hospitals? Basically, it's teams of people that have various expertise that come together. I can't take care of someone with Chiari Syringomyelia without Kimberly Sexton, with many years of experience as a nurse practitioner. Deborah Truex, who is a nutritionist, head of nutrition here. I can't do it without Stephen Ramirez, who works with me side by side in each surgical case. And these are just a few. Lucy Tyler, who manages the neuroscience program. So again, maybe I get to stand up here and talk, but there's a lot of folks that make this possible. This hospital is actually a fairly unique hospital. Come on in, please. It's a Leapfrog Top General Hospital for the second consecutive year. This is a group that businesses in the U.S. that want high quality care out of our hospitals. Center for Medicare Services 5-star rating, U.S. News and World Report for top regional hospital, and a magnet hospital in nursing excellence, again for the second year in a row. If you take all these awards, there are only 12 hospitals in the United States that have met all 12. Last night, the Chief of Staff had a session here, and he's been here for years, if you will. He's now head of the Medical Executive Committee, and he put it this way: this is a tertiary hospital that hasn't lost its community roots. And I think for all of us, certainly myself, that work here, it's a great medical community. Let me leave it at that. Let's get down to work now, okay? I always, or mostly always, start with a review of the anatomy. We all want to get on board, okay? And there are these wonderful drawings, this one from Frank Netter years ago, that shows us our brain and the fluid pockets within the brain. Spinal fluid is created inside these fluid pockets. It has to drain. These two ventricles, they're called, have to drain through little openings to the third ventricle, down this narrow tunnel to the fourth ventricle, and it better get out, and it gets out through two side openings and one opening in the center. I'll come back to this in a little bit. Here's another look at it. With each heartbeat, we're all making spinal fluid, continuously. It better get out as it's coming in. It has to find its way, again, 2 drain openings on either side here that don't get affected with the Chiari malformation, and 1 down here called the foramen magendi that does. So we begin to understand that Chiari is not just an anatomy defect. There's even a question of should we call it a malformation, okay? It's a dynamic process, likely for most people, on top of a small skull base being the problem. So let's get further down and let me share over here on this screen. If there's bone at the back of your skull, it ends there. This is a side view. The face is out here. This is the back of the head. This is a bone at the base of our skull. It ends there. From there to there is the hole at the bottom of our skull. It's the big opening. Therefore, it's called the foramen magnum, the large opening. Okay? We see the cerebellum. We see the brain stem turning into the spinal cord. And we see a fluid cistern, a fluid pocket, if you will. And hundreds of years ago, when it was named, they call it the cisterna, a cistern, the cisterna magna, the large cistern. And that's important to think about as we talk about Chiari. If you look at that same area, and these are beautiful drawings from the Barrow Neurological Institute, this is the cerebellum from behind. These are 2 nubbins that hang down, and somebody called them tonsils. And a lot of people are confused and look at me, look at their daughter and say, "You're going to do what?" But they're called tonsils, and you can imagine why. But this is a critical area. These are the vertebral arteries that are feeding the back part in our brainstem and our cerebellum. These are arteries coming off that are feeding the brain stem itself. So obviously a surgery in this area has to be fairly delicate. Let's put it that way. Okay, so get a sense of the anatomy. So what is Chiari? And I think most in this group will probably know that Hans Chiari was a pathologist in Prague in the late 1800s, and in postmortems identified a variety of malformations that were later called the Chiari malformations, and we deal with Chiari type 1. Okay? Type 2 is you'll know it in newborns because they're most likely going to have a sac in their back, and they have actually a worse malformation, although not all of them need surgery. So this, and Kathy, this is a slide that we were talking about. This is the one slide that defined how we measure Chiari. When do we call Chiari? There's only one slide historically that I'm aware of. It's simple, and it's too simple. So the young folks out there, the young neuro researchers, need to tackle this definition issue. We have put all our eggs in this basket that we're going to draw a line here and measure the amount of herniation. We know it helps for most people, but as many of you know, there are some people that can have only a few millimeters of herniation and have significant problems. It has to do with the amount of crowding, but I'll get off my soapbox. The other thing is that Kathy Posnick was telling me that if you give scans to a number of neurosurgeons, you're going to get different numbers for herniation. And probably some of you have had that same experience, okay? Because there's a disagreement of where you draw the line. And depending on this is a classic drawing, but if you draw the line at the bottom of the skull, you might get a slightly different measure. But this drawing, in my mind, confirms that the initial definition was based on the tightest point. Okay? But I'll leave that as an aside. This is a happy situation. Okay? This is the bone at the base of the skull. It ends there. There's the other base of the skull bone here, back of the skull. Draw a line there. There's a nice cistern there. Those tonsils are relaxed. This is good. Okay? This now we're starting to see some changes. You draw a line from the base of the skull there to there. Those tonsils are, if you will, plugging off the hole at the base of our skull. Okay? But just looking at the tonsils is not the whole picture. Let's look here. This is the lower brainstem. It has been stretched. It is long, it is stretched. The tonsils have caught on this tubercle. It's a little bump, we all have it. It gets bigger as the pulsations of the brain, and I'm going to talk about those in a minute, it's stretching this. So congenital problem for most, probably, but there's a dynamic process going on throughout a person's life. Look at this brainstem, very long, very jammed here. Where's that cisterna magna? How's the drainage out of that opening of spinal fluid? Look, now this is another image that's not used a lot, maybe it is. And there, we need to think about adding this to how we describe Chiari. This is a cross-section image. So looking at the crowding through the foramen magnum, you can see the little line where it was taken. This is very helpful in understanding Chiari. This image has not been quantified that I'm aware of. Why can't we measure it on the coronal images? We can now with MRI get a coronal image. Why are we always measuring it on sagittal? Coronal MRI tells us that the left tonsil is bigger than the right tonsil. The question is, what is normal? And then, and then you go from there. What's going on here? Look at this brainstem, totally stretched. The tonsils are very pointed. It's a compressed brainstem. And then you add some folks with bone anomalies where C1 is fused to the skull. C2 basically is sticking up into the the pons area of the brain. So these are bony anomalies that make it even worse. So it's a wide range, I think, is the picture I'm trying to get here. I'll just have a slide on Syringomyelia so we don't leave that out. Because of this obstruction here, fluid starts getting into the spinal cord. That's called Syringomyelia. The cavity itself you can call a syrinx. I'm convinced that in the 50s and 60s, when people were told, well, you have spinal paralysis, and they didn't know why, and you're going to slowly get paralyzed, some of those people had this condition. Now with CT, we had initially, and then MRI, we can find these. But the bottom line is, the issue with Chiari is people that are suffering from Chiari don't walk into the doctor's office with their scan. They haven't had a scan. What they have is symptoms. What we need to teach, and again to the young audience that wants to grow and expand our knowledge of Chiari, we need to simplify and teach the neurologists and the family practitioners what to recognize, why the headache is different, why it's not migraine, why it's not tension. And there are some clues, actually some pretty strong clues. Let's look at them. Headache is the most common. Anywhere from 94 to 98% in studies will have headache, but the headache is different. A lot of people have headache. Not everyone has Chiari. So how do we determine? First of all, it's usually suboccipital in the back of the head. It tends to move forward, but it can be on one side. It's usually a severe pressure. We're going to get to that word, pressure, in a minute. It's often explosive. And the explosive part is Valsalva. When we do things that are tightening up our abdomen and increasing the pressure in our chest, that's called Valsalva. So coughing, sneezing, laughing, cheering. How many, if your headache is caused by laughing and cheering, it's likely not migraine, okay? If somebody tells me, a young man tells me, I don't want my friends to make me laugh because I'm going to pay for it. I can't cheer at the football games because it's going to hurt my head. There's something dynamic. There's something going on with the flow. Something is obstructed, okay? And we'll touch on that in a minute. I've had several. Well, I thought you always had bad headache with a bowel movement. That's all I've ever known, okay? Worse with looking up. How do we crowd that area more? You look up at your upper kitchen cabinets. So these are questions that could be asked of someone and then begin to get a pattern that maybe we need a scan here. Maybe it's not migraine or one of those other conditions. Here's what they say. Severe pressure in my head and neck. Feels like my head will explode. Feels like someone is blowing a balloon inside my head, like my head will pop off. The headache is accompanied with a variety of other neurologic symptoms, and there are so many other symptoms that somebody will go into the ER and it just won't make sense. You've got headache, you've got numbness here, your face is numb there, you're complaining of not saying the right word, your thinking's off. You must be depressed, you must be anxious, or maybe you had a panic attack. Okay? And these are folks that I've seen that have found that in the ER. So, what is going on? We are stretching and harming and causing dysfunction in the brainstem, spinal cord, and part of the cerebellum. And I'm going to go through this quickly. The message is that in this area is the most complex neurological area that we know of. Okay? Yes, there are other complex areas like the thalamus, but there's so many systems. Okay? Your tongue movement, your speech, your swallowing, all of these areas, these nerves are in the lower brainstem that's affected. I'm going to maybe let you read those. Even trigeminal neuralgia, but dizziness, vertigo, hoarseness, etc. Okay? The long tracts that allow me to move my arm from here to here are going through that area. The sensation that's coming up is going through that area. So numbness, tingling, weakness, etc. The breathing centers are right in the medulla. The cardiac centers are mostly in the medulla. The consciousness centers also run in the medulla. So should we be surprised that some people are going to present with fainting? Okay? Because they're so squeezed and their brainstem is not getting the blood it needs. What about cerebellar fits? They've been described in young children, very young children. I believe I've seen it in 17, 18-year-olds. They're not very common. One was a young woman, late teens, went to church. Easter Sunday, the church was crowded. They stood in the back. And the father, it was her and her father, the father said, she said, I want to get a drink of water, which she said to me, that was sort of unusual for her. She would have done that. I turned to look at her, and she was doing that, and I caught her, and that's the first symptom of her Chiari malformation. Or a child that'll have a spell that looks like a seizure. Fortunately, they tend to arrest in 15 to 30 seconds. 30 children in one study were reported. All of them had EEGs. Only one had a positive EEG. This is brainstem ischemia. Now, some people have nausea or vomiting with Chiari, right? I have a young high school girl who had to be homeschooled. She was vomiting several times an hour. She had a complete GI workup. It was totally negative. They eventually went to another clinic. She had a repeat GI workup. It was totally negative. Somebody finally got an MRI, and it was a 17-millimeter Chiari malformation. And some of you that have Chiari know that that's quite a severe. She had a decompression at our center. Fortunately, she did quite well. One of these young women that says, I think I'm going to be a doctor, and you never know, right? But there's the nausea and vomiting center right there, right underneath the cerebellar tonsils. So we need to think about these cases. Now, this is a less recognized, and it's a fascinating disorder. Ms. Posnick tells me that on their website, one of the presentations called Chiari in the Mind is the most popular visited video. And it's because we used to think that the cerebellum was primarily coordination, right? That's how I grew up. I think, people who probably have a very beautiful cerebellum are people like Beethoven, maybe musicians, someone that can really coordinate. That's what we think of it. However, we are now learning that there are other functions here, especially in the back area, not the tonsils, that have to do with cognitive function, which is thinking, right? Higher order cognitive functions. Okay? So what do the folks complain of? Deficits in executive function. That's higher level decision making. And I've certainly had folks tell me, I gave up the promotion. I just didn't think I could do it. They have difficulty finding the right word. They'll say the wrong word. Their child will look at them, Mom, what did you say? Okay? Their working memory is affected. That's the short-term memory. They have difficulty multitasking. So these are now known and understood to be actual symptoms of the Chiari malformation complex, if you will. However, there's also anxiety and depression, and deficits in expressing emotion and behavioral regulation. So I've certainly seen some children that they're very well behaved in the clinic, but when I bring these issues up, Mom looks at them kind of like, yeah, we've got some of that going on as well. Okay? So a very complex neurologic syndrome. This is probably, I think, one of the more unusual presentations. There's only 2 cases that I've known about, that I've read about, and it's called paroxysmal rage. A 2-year-old boy, it's two children. One is a 2-year-old boy. He will rage for 3 to 4 hours and just get exhausted, cause unknown. The girl is 11 years old. She rages, but she'll rage all day long. She'll break furniture, she'll kick, she'll bite, she'll scream. Neurosurgeon in the South treated both the children. Both had very severe Chiari malformations. 1 year after, and this is written in the literature, 1 year after surgery, the boy was just fine, the toddler, and the young woman, 11-year-old, was described as pleasant and engaging. So a lot of effects. I'm not going to spend a whole lot of time on surgical treatment because I want to get to a couple of other disorders, but just some idea of it. I've given you an example of a pretty severe Chiari malformation. This is not a normal medulla. It is being squeezed, it is stretched, it is narrow here, so it's being squeezed between these tonsils that are herniated below cervical 1. They've caught on the tubercle. It's stretching the medulla from there to there. That's a pretty bad looking brainstem. So this person's going to have a lot of symptoms, rightfully so to speak. What's our goal? Reestablish spinal fluid flow here and relieve the compression to these tissues. Okay? What I try to teach is that there's a choke point, and our work as surgeons should be at relieving the crowding at the choke point. For most people, the upper cerebellum is just fine. The pathology is here. If you do too much, you're doing too much. If you do too little, you're not getting rid of the compression, and we'll talk about that in a minute. But everything we've seen are pictures, okay? You've got a picture of a party, of your pet or whatever. We can recognize them, that's a picture. But a video is more what your pet is like, right? What about a video of the brain? Okay, we've just been looking at pictures. What we need to know is that, let me back up, is that the brain with each pulse gets bigger and it moves. And we have on average about 100,000 pulses, heartbeats a day. And it gets bigger and it's going to move down and forward. It's going to move down and forward, pulse, 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 pulse. Okay? So, if it's getting bigger and it's got spinal fluid all around, and spinal fluid is essentially water, and water is incompressible, and the brain is getting bigger with the arterial pulse going in there, that water better get out of the head right away, okay? And it's going to get out of the head and go into the spinal canal. So many of you in the room can cough and sneeze and your head is not going to blow off or feel like it's going to blow off. What about if you can't, if you expand and plug, oh my God, that pressure is going to be like a balloon going off my head, like an explosion. It's explosive. Okay, so this is a dynamic process. All right, now I'm going to just bend your mind just a little bit. I think we'll all get there, but this is the best way I could try to illustrate it. Here's the same case, a very severe Chiari malformation. Okay, Now we're going to put this scan in a surgical position. Okay? So focus on this area here. Look at this shape, the tonsils. Now we're in a surgical position. Okay? A little bit mind-bending maybe, but we're focusing here. The surgeon is going to come back from here. We're going to focus on the tonsils and this little hump here, the cord, and this is a bone called the odontoid that it's dragging over. It's being pulsed over. Let's look. Is it? I don't know. Maybe it isn't. Now, that's the same view. I've just narrowed it to match the ultrasound in surgery. What does that mean? How do we get that? We've taken the bone off here. There's an opening in the back. Muscles are spread apart. The bone is removed. We're going to fill this area up with water. We're going to put an ultrasound in it. We're going to get this picture. Okay? And I think I may have to trigger it over here. So sorry for walking across. I'm going to let that run a little bit. That's happening 100,000 times a day. That, with each heartbeat, you're jamming, it's jamming over here, you're stretching things out. Just doesn't look very healthy. Did y'all get to see that well enough? Should I run it one more time? Maybe just one more time? Sorry for the walking in front of the screen. It's just, shoot. That's the video motion. That's what's going on in the brain. The static picture, the MRI, is just a single shot in time. This is really what's happening. So can you imagine if somebody's coughing right now, what that might look like? Or cheering at the game, and oh my God, because they went like that, okay? So that's what we're trying to relieve. And I'm just going to give you a few pictures, okay? When the dura is open, those tonsils in this case are saying, oh, thank you, I need that room. And I'm going, wait a minute, I need the room. The patient needs breathing room in there. You can't be doing that, right? We got to let this relax, okay? So sometimes we have to reduce the tonsils. We are going to avoid major vessels, obviously. Generally, we don't see a neurological effect of that. Frankly, the cerebellum on this slide is really quite big. But that's where that hump was, those tubercles. This is the fourth ventricle, which is stretched down low. This is C2, so the brainstem is down in the cervical canal, is where it ended up. And this is a before and 1 year after. We've got a healthy brainstem. We've lost that hump, just a gentle rise. The compression is gone. This person is going to feel a lot better than before, okay? All right, one more thing before I go into these two other disorders, which is my main mission. Every clinic in the nation that is specializing in this probably has different areas that they're subspecializing in. For instance, I talked to a couple of families earlier about EDS, Ehlers-Danlos syndrome. And there are certainly some clinics in the U.S. that are seeing more of those folks. One of my interests has been for the past 5-7 years is why does surgery fail at times? So we're very interested in evaluating and teaching others about surgical failure and how to avoid it. And I'll just give you one example. So this person, you can see, has had a posterior fossa decompression for the Chiari malformation is what it was done. This white, large white area is fluid that's building up in the spinal cord. Okay, that's a big syrinx. Thankfully, in today's world, if you do a decompression for Chiari in someone with Syringomyelia, high percentage you can stop that syrinx from growing, and for most people get it to shrink. But this lady, who was done in another state surrounding us by a very good neurosurgeon, the syrinx did not respond. And you could argue, well, didn't respond, most people do, yours didn't respond. Syrinx is a real serious condition. I mean, it could eventually put you in a wheelchair, right? So the surgeon didn't want that to occur. So then they did a 2-level laminectomy. She's in her 40s, so they took 2 of the roof bones in the back of the spine, opened up the sac, and in the center of the cord you can make a small little opening and slide a little drain stent, called a stent, to drain the syrinx. It didn't improve with a Chiari decompression. Let's see if we can improve with a stent. Then she would notice every now and then that she would make certain movements and jump because it was tweaking. You put the stent in, and then the other part of the stent you tag to the sac so it doesn't just slide out. So it's a bit anchored. So the third operation was to take the stent out. She got fed up with the medical system, but about a year later came and visited us. And the one thing that is most important is to read the operative note. So she's had 3 operations, wants to come to our clinic to get an opinion. I read the operative report. The decompression, the way it was done, I had no real argument with it. It wasn't too small, it wasn't too large, et cetera, et cetera. But I looked, and there's no mention about that drain, that foramen of Magendie, which I showed y'all at the beginning, right? That's an important drain. There was no comment about it in the op note. Was there a congenital veil covering it? Was it opened? Or was the drain opening looked at? So I told her, and we saw a few mild adhesions. I told her, I said, you know, I just don't see that there's any comment about the opening here, and I am concerned that you're driving fluid through your cord into this, and you do have a few adhesions. And she said, what else am I going to do? I can't live like this. So anyway, the long and short of it is, went in, separated the tonsils. This was there since birth. It's a retained rhombic roof. It's a congenital veil. It's a congenital veil. We need to teach that if you've got Chiari malformation, you need to look between the tonsils, because 8 to even 12% of people are going to have a veil. If you don't take care of that veil, the syrinx is not going to go away. I found a few minor adhesions that were not an issue. So now take a look. There, I'm exposing it a little more. Is there a way to darken the room a little bit? Is Lucy around? Just because these are... Okay, that's much better. Again, this kind of spidery area, you'll be able to see it here in a minute. Again, I'm separating it more. There, with a fine knife, we're starting to see the 4th ventricle. I'm opening that veil. This is the one that probably shows it the best. This is her 2 months later. So Chiari is not the hardest operation that we do, but there are steps to it, and it's taking those steps that's the most important part. All right. Though finally, those 2 hidden headache disorders. What are those going to be? There are a lot of other Chiari's difficult, if you will, or takes time, or should take time, because we have to think not just of what we see of the Chiari that we could look at and say, you've got Chiari. We have to ask ourselves, first of all, is it a true Chiari or something else causing it? Okay. Or are there some of these other disorders? Again, we talked about, or I mentioned connective tissue disorder, EDS. I learned that the university is going to host a big EDS conference coming up, and I'm excited to be able to go to that. Okay. Craniocervical instability, occipital neuralgia, cervicogenic headache, tethered spinal cord, and frankly, there are more. But we don't have time to get into that. These are the major ones. I want to talk briefly about these 2 conditions. Idiopathic intracranial hypertension. You might know it as pseudotumor cerebri. Okay, moving on. Here's a lady who's undergone a posterior fossa decompression for the Chiari malformation, and there you see the surgery. There are the tonsils. There's room that was made, bone was removed, room that was made. The surgery looks fine. The patient is no better. Well, that doesn't make sense. So we have to look at this scan a little closer. The more you look at the whole scan, you're starting to think, you know, that's kind of a full brain. I don't see a lot of the spaces that I normally see. Why does that brain look so tight? If I look at cross-section images, boy, those ventricles are pretty tiny for someone who's in her 40s or so. Okay? So, briefly, in looking for the northeast passage in the 1500s, Barents, who was the captain, he led the expedition. And a Dutch officer, Gerrit de Veer, reported in his diary that a lot of the men in the ship were having headaches and dizziness and blurred vision and a lot of the symptoms that our Chiari patients get. Okay? And it was finally realized they were eating a lot of polar bear liver. And it was vitamin A toxicity. And vitamin A toxicity causes brain swelling, pseudotumor, with symptoms very similar to Chiari. And some patients have been operated on for pseudotumor thinking it was Chiari. We'll go into that. So, I've mentioned that. And I'm going to let you just look at this, but the symptoms are fairly similar, right? Headache, dizziness, visual dysfunction, double vision, nausea, vomiting, tinnitus. Okay, that's pseudotumor. Why do I bring this issue up? Because it's a risk to have surgery if a Chiari patient also has pseudotumor cerebri. And I'll just give you a couple of cases. 6 days after a Chiari decompression, 12-year-old girl developed gait unsteadiness, headache, vomiting, drowsiness, swelling in her eyes. The CT scan showed cerebral edema. Fortunately, she responded to steroids. Again, she had pseudotumor. This person, a little more serious, 24-year-old, 7 days after Chiari decompression, she came in coma, slow heart rate, dilated pupil, marked swelling in the back of her eyes, her eye nerve. She was intubated. She had diffuse swelling on CAT scan, a venous stroke. She was weaned off the ventilator but was left with some palsy in the eye movements, facial movements, and part of her visual field. That's doing a Chiari operation on a patient that looked like they had Chiari but primarily had pseudotumor cerebri. How often does this happen? Are those unusual cases? This is a report of 68 pseudotumor patients of the brain. If you look at pseudotumor patients, 10% will present with what looks like a Chiari malformation. So there's an association there. And in reverse, this is Dr. Frim, his team. Many of you might know that name. He's from Chicago, a pediatric neurosurgeon, does a lot of Chiari work. He looked at 192 patients that had a Chiari decompression. He looked at the 36 that had failed the decompression. He found 15 had elevated pressure. So of those in his study that failed his surgery, 42% pseudotumor cerebri. So we better learn as a group to recognize it. And I think many people do. I don't want to overstate it. We look at the back of their eyes. We check for visual palsies. But this is an important slide. Okay? What can cause pseudotumor? So we need to ask. And the more folks that are affected tell us, hey, I'm on that specific birth control medicine that you talked to me about, and I've had headaches and dizziness. So it's a sharing. We have to work together, right? Now, I've only outlined a few in red just to keep in mind, but prolonged steroid therapy, pregnancy, oral contraceptives, anabolic corticosteroids, and the Norplant implant, minocycline. We had a young 17-year-old, bad pseudotumor, but a bad Chiari. Couldn't operate on her and take the risk. It was her acne medication that had to be stopped. There are 116 of these cases under investigation in England. This is just this October, or last October, how a contraceptive nearly killed me, and it was her pseudotumor that it had caused. A few other things, bad sinuses, sinusitis, lupus, and a thrombosis of the vein or some other things. But the main cause of pseudotumor is that we're surrounded by inexpensive, high-calorie, and low-nutrition food. We tend to blame ourselves, but if we look around, we're surrounded by this. How can you drive on a trip and stop at a Quick Mart and not be faced with shelves of this, okay? So elevated body mass is the main cause. And fortunately, even a 5 to 10% weight loss can help that. Kimberly Sexton, if I don't run too long, is going to talk to you, and Deborah Truex, about our wellness program. So wellness has to be a component of care of folks with these conditions. Well, care of all of us, right? Let's move on. This is a little bit of a scary condition, I think, because it's hidden, okay? This is a 41-year-old woman. She underwent a Chiari decompression. She presents with 8 years of progressive headaches. They're postural. They're worse when she's up. They depend on posture. More recently, severe nausea and vomiting. You can see she's had a Chiari, bone has been removed, right? Let me show both sides of the screen. Bone has been removed. There's a Chiari, but it's about as herniated as it can be, right? It's a bad situation. Looks like they did a pretty big operation. We're really crowded here. This is before here, and this is one of the clues, this enhancing here. This is, so she had spinal surgery for this problem, okay? All right, you've got a pool, or you know a neighbor, or you've been to a pool, and there are all these floaty toys. This is all I know how to call them, okay? And you drain the pool. What's going to happen to those floaty toys? They're going to go down the drain. This here in her spine, this sac, weak sac, was leaking spinal fluid. Constant leak, the brain went down. It looked like Chiari. A Chiari operation was done that didn't help, but the real treatment is there. That's the formal name, spontaneous intracranial hypotension. So if we see Chiari on a scan, we have to ask, could it be this condition? I'll tell you how to recognize it a little bit. It's a chronic spinal fluid leak, usually through the spinal sac, causes the brain to sag and plug off the foramen magnum. There are some cases that have been reported of CSF leaks from the ear, but usually it's the spine. Basically around 40, the symptoms can come on abruptly or gradually. But here's, have you had spinal trauma? Maybe it's a bone spur. Maybe you've had spinal surgery. Maybe multiple lumbar punctures, epidural block during pregnancy. And the lady tells me, well, they did 7 sticks. And you're starting to think, okay, maybe we're leaking, and the brain's drooping. Okay? Let me show you this slide. Fortunately, there are a few things that are a little different, but we have to keep them in mind. There's usually more nausea, vomiting, and just not hungry. Pain between the scapula. Hearing changes. They feel like an echoing. Their tastes can change. There's mental confusion, and in some, significant mental confusion. And probably the most serious case, she didn't have Chiari with it because her tonsils started up way up high. Anyway, the long and short of it, she's waiting for her order at a drive-in at McDonald's. 2 young men in a big truck, bam. She whiplashes, gets initially managed, medication, this and the other, but goes on for 7 or 8 months, multiple workups, and then gets referred to us. And one of the things she said is, you know, I think I'm going crazy. Now, if people are going crazy, they usually don't know it. Am I right or not? I don't know. So that was odd. And bottom line, in her, she had ripped the 2 nerves and was leaking spinal fluid. I actually had to go in and tie them off. So this condition occurs, and fortunately there's a good treatment. Let me go to what's really important. So here is what looks like a Chiari malformation. But there's fluid collecting on the surface of the brain, there's enhancement of the brain, the veins are enlarged, the pituitary is fat. Once the leak is taken care of, the tonsils came back up some, and the pituitary is much more normal, and the headache syndrome. So again, there are other treatments, conservative treatments, but basically, if we identify one of these, we can do a blood patch here, even though we might not know exactly where it is, and that can be effective. And if there are questions, we can deal with this. I know it's a different. Here's another. It looks like Chiari, doesn't it? Now I don't have the after. This is a CAT scan of her back. They put dye in her spinal canal, and the dye was leaking out. This is all dye leaking out. So she's leaking. The surgery, the treatment, is there, not up top. Because basically you open that up and the brain's going to go down a little further. Okay? I've done a few of these where we've tried blood patches. It hadn't helped. Here's a blister kind of that would leak. And the illustrator, they wrapped some muscle around it to try to stop the leak, etc. I think here's the final one on that, which to me is the most impressive in the literature. This looks like Chiari on your left. And this is after a minimally invasive repair of a CSF leak. And look where the tonsils are now. I think if that scan doesn't convince us that we need to be more aware, because you walk into an office like that and somebody may get a Chiari decompression. Okay? All right. And we need your help, all right, in that. So we're winding down a little bit. Briefly, Colorado Chiari Institute. There's our logo and all. But this is a team, and this is only part of the team. Kimberly, that you'll hear about. Chris is the glue to our institute. She keeps everything going. Dr. John Scott is our Chiari neurologist. Dr. Michael Priest is our Chiari neuroradiologist. Cynthia Myers, the head of talk therapy, and Deborah, who's going to speak to us today, is the head of nutrition. So it's certainly, again, quite a team, and there's a lot more than that. What are we treating at our center at this time? We're treating Chiari 1, we're treating Chiari-related Syringomyelia, Chiari-related tethered cord, and other associated Chiari disorders. And we've recently added non-Chiari Syringomyelia, because I have quite an experience with that, with trauma, etc., and also non-Chiari tethered cord. So that's the range of our treatment. We probably should put on there that we see quite a bit of revision, people that are possibly candidates for revision surgery. We just did one of those surgeries Monday there. I have identified 7 causes of failure. I've spoken about that in Sydney, Australia, in Milan, and I was blessed to be able to go to China. And I'm speaking on that in about a month at what's called the Southern Neurosurgical Society to get the word out. I think if people understand why Chiari surgery can fail, hopefully that'll be a way to say, well, I don't want to get into that trouble, so maybe I'll do it differently. And on that, I'll say thank you.